Uh, Dear friends, this is our 11th update of spine webinars. We will start with a new subject. I'm sure we will discuss many new things and we will clarify our ideas on that. I will give the word to moderate the session to Salim Şentürk.
Thank you, Dr. Seleli. Today, welcome everyone. Today, we will talk about management of osteoporotic vertebral fracture. We got three speakers. And first speaker, Dr. Se-Hoon Kim from South Korea. He will talk about non-surgical treatment of vertebral fracture. And second speaker, Dr. Ender Friolo. He will talk about augmentation techniques in vertebral fracture. And third speaker is Dr. Mehmet Aydoğan. He will talk about indication and techniques of open surgery in vertebral fracture. And we can start with Dr. Kim. Dr. Kim, please.
Yes, I'm gonna share this screen.
Yes, please.
Hi, everybody. I'm Dr. Kim from Korea. It's midnight, Seoul in Korea now. Can you see my slide, PowerPoint?
No, yes. Good.
Can you see? Okay.
Can you do full screen?
Yeah, full screen. It is.
Perfect.
Okay, everybody, can you see mine?
Yes, good. Perfect.
Okay. Yeah, so my topic this evening is the non-surgical treatment of the osteoporotic vertebral fractures. Just a second. Okay. So I'm so much honored to speak as the one of member of International Academy of Spine. And at the end of the lecture, I'll introduce several papers published by the WFNS Spine Committee 2 years ago. So I think three of speakers will share this hour. Regarding the osteoporosis, we know that this is the most common metabolic bone disorders in the human. And the clinical symptoms and consequences, some patients does not have no symptoms. But when the fracture happens, the patient may feel painful, the fragility fracture, sometimes deformity, bone pain, and sometimes spinal stenosis from the fractured fragment, and very rarely Cauda-Equina syndrome can happen. Osteoporosis is known by some doctors as the silent disease with no warning signs, and sometimes a quiet thief, because until the osteoporotic fracture occurs, there is no warning signs in the osteoporosis. So not only the immediate surgical concerns, but also medical evaluation and optimal treatment for the underlying osteoporosis are very important. We know that from the WHO definition of osteoporosis, a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration, and finally increasing the bone fragility, and finally fractures. And in the bone mineral density study, T-score minus 2.5 or less is the osteoporosis by definition. Compared to the osteoporosis, osteopenia is between the T-score between -1 and -2.5. And when the patient, the osteoporosis below -2.5, along with the fragility fracture, it is called the severe osteoporosis. What about the osteoporosis in the premenopausal women? and men younger than 50s, and children. In those the groups, WHO criteria of the osteoporosis cannot be used. The International Society of Clinical Densitometry group, they recommended the use of Z-score, age-matched Z-score rather than the T-score. So Z-score under the minus 2.0 are defined as below the expected range of age. And those the patients need prompt search for the secondary osteoporosis. When you check the PubMed regarding the medical treatment, medical management, and osteoporosis, vertebral fractures, there are a lot of papers since 1974, but more than half of the papers were published during the last 10 years. This is very interesting paper published by Turkish group, an overview and management of osteoporosis. They mentioned 1/3 of the women and 1/5 of men over the age of 50 years will experience the osteoporotic fractures in their lifetime. This is quite many the incidents. In many the articles, well-known the vertebroplasty or kyphoplasty can give a better quality of life after the osteoporotic compression fracture happens with less pain. In some the literatures, as you can see in this paper published at the NEJM 2009, this was a randomized trial of vertebroplasty versus conservative treatment in the osteoporotic vertebral fracture patients. Their conclusion was improvement in pain and pain-related disability were similar in both groups. So it means the vertebroplasty can be unnecessary. What about this paper? This paper was regarding the conservative management of the osteoporotic vertebral fractures as the prospective study. They concluded the multidisciplinary conservative treatment is effective and essential as the primary treatment for the patient having osteoporotic vertebral compression fractures. This multidisciplinary treatment can alleviate pain, decrease disability, reduce mobility, was effective, especially preventing the future the osteoporotic fracture. This paper was regarding the non-surgical management of the osteoporotic vertebral compression fractures, published in 2017. Interestingly, in their conclusion was, unfortunately to date, the current understanding and knowledge for the non-surgical management for acute osteoporotic vertebral compression fracture is inconclusive. But this is one of the well-known diagram algorithm of the conservative management of acute osteoporotic vertebral compression fractures. As you can see on your right hand, when the patient is symptomatic, they need pain management through the many analgesics such as NSAID, opioid, muscle relaxants. And on the other hand, they need the rehabilitation such as brace, bed rest, exercise, and fall prevention program, and so on. Even the patient is symptomatic, fall prevention program is necessary. These are the principles of non-surgical management: relief of pain through the many medicines, and rehabilitation, such as physical therapy, improving the quality of life, and assessing the risk and benefits. I'm going to talk about the non-surgical management for osteoporotic spine fractures in 5 categories like this: bed rest, medicines, rehabilitation, and chemotherapy or medical therapy for osteoporosis. This algorithm was published by my paper and Dr. Zileli. We published in 2022 regarding the WFNS Spine Committee recommendations. I also concluded in this algorithm, as you can see, in the osteoporotic vertebral fractures, as the non-operative treatment, we need chemotherapy and rehabilitation, such as strengthening exercise, balancing, assistive devices to prevent repeated falls in the patient. So first of all, I'm going to talk about the bed rest after the osteoporotic spine fractures. Is regarding the initial hospitalization with rigorous bed rest followed by bracing and rehabilitation in the osteoporotic vertebral fractures in Japanese group. They concluded there was no severe adverse event related to the initial bed rest. However, the initial hospitalization with rigorous bed rest followed by rehabilitation program using a lot of the many types of brace was safe and feasible treatment. Then what about the period of bed rest? This is the published by Korean group. They compared 1 week bed rest versus 2 week bed rest. And they compared the X-ray images. In the result, there was no difference in outcomes according to the bed rest period. However, complications like constipation, difficulty in urine, indigestion, and so on were significantly higher in the longer bed rest groups. Then what about the medications for pain relief? Most commonly, analgesics such as acetaminophen and NSAID are useful. Sometimes, and personally, me too, I'm pretty much prescribing opioids if the patient still painful through the common analgesics. And muscle relaxants are used for short durations, such as 2 weeks. But we have to keep in mind that when we're using the muscle relaxant, the side effects can be drowsiness, dizziness, and so on. And the osteoporotic medicines such as bisphosphonate and teriparatide, they are also known to have the pain relief effect. Bracing. The braces are very useful to relieve the pain by stabilizing the micro movement in the fracture side and in terms of early mobilization and preventing back fatigue. The ideal brace should be lightweight, easy to wear, comfortable, and should have the cushions at the pressure point, and the braces should be custom made. The choice depends on the patient's need and the physician's need also. These are some examples of braces. Commonest is the tailor brace, as you can see on the left hand, and sometimes joint hyperextension brace are also very common. This kind of TLS brace with or without shoulder rest are also common in use. And some doctors are using the ultrasound therapy, hydrotherapy, heat or ice application, and especially in Korea, acupuncture. But these have no evidence-based proof yet. And what about the rehabilitation in those osteoporotic spine fractures? Many attempts to decrease the kyphotic deformity are improving the paraspinal muscle strength, they maintain spinal alignment, and finally prevent the falling, repeated falling. The falls are the cause of majority of osteoporotic fractures, so the prevention of falls is very crucial. The older and frail patients and those patients who had stroke are taking the medication that decrease mental alertness are also very predisposed to falls. So several interventions reduce the risk of falling. The weight-bearing exercise, back strengthening, balance training, and selective use of orthotics are also very important. There are several risk factors for the falls in community dwelling or the patient. As the environmental risk factors, loose throw rocks in the surroundings, low-level lightings, slippery conditions in the environment. As the medical risk factors, vision, dehydration, depression, orthostatic hypotension, and so on are the risk factors. And there are multifactorial interventions to prevent falls in the community dwelling or the patient, such as appropriate the exercise program, withdrawal, or minimizing the psychoactive medications such as hypnotics, anxiolytics, and antidepressants. And treatment of postural hypotension, and selective use of orthotics, and so on. The role of exercise. In this paper, they concluded long-term regular exercise program designed to improve postural stability, mobility, and mechanical efficiency. They are very important, alongside with the increased vitamin and calcium intake. The modern rehabilitation aspect, the use of modern spinal orthosis helps to reduce pain and improving the postures. The success of rehabilitation in the osteoporotic patients through the individualized educational approach is important. How to prevent further osteoporotic, the compression fractures? Again, as I mentioned, the multidisciplinary approach is required to prevent the fall. And using the FRAX protocol, we can assess 10-year risk of vertebral body compression fractures, and the periodic check of the bone mineral density and vitamin D, calcium intake is essential. Finally, regarding the medical treatment, I'm gonna briefly mention regarding the medical treatment. This table shows the categories in three regarding the pharmacologic agents of osteoporosis: anti-resorptive agent, anabolic agent, and the calcium and vitamin D is the fundamental supplement in any cases. Most of the medications are known. They are proved to improve the risk. They are approved to decrease the fracture risk, compared to some medicines are not approved for the hip fracture, as you can see in this table. Regarding the medical treatment for the osteoporosis, first-line treatment is known to be bisphosphonate and monoclonal antibody. When the first-line treatment fails, we can use the Raloxifene, teriparatide, strontium. The bisphosphonate is most widely used drugs even in Korea, but the optimal duration of therapy is unknown yet. Oral bisphosphonate may induce the upper GI discomfort and disease. Intravenous bisphosphonate may induce acute phase reactions such as fever, muscle aches. And when we are using the bisphosphonate, drug holidays are required. After 5 years for the oral medications such as alendronate, risedronate, or ibandronate, and after 3 years for IV bisphosphonate such as zoledronic acid, to prevent the osteonecrosis, as we know. Finally, I'd like to introduce the 6 papers published by the WFNS Spine Committee 2 years ago under the name of Osteoporotic Spine Fractures. And I'm so much grateful to Dr. Zileli. He was the chairman of the spine committee, and we were able to publish these 6 papers at the Journal of Neurosurgical Science in Italy. These are the front page of the 6 papers. This is my conclusion. As I mentioned, the osteoporosis is a very quiet, thick, silent disease with no warning signs. So the prevention is essential. And again, 1/3 of women, 1/5 of men over 50 years will experience the fractures related with osteoporosis in their life. And a multidisciplinary approach for the conservative treatment as the medical treatment of osteoporotic vertebral fracture is essential. And current literature still supports endocrinologic medical management and rehabilitation when the patient has osteoporotic vertebral compression fractures, even though there is weak evidence in the many literatures. So we need the high-level evidence studies to determine the management effectiveness in the osteoporotic vertebral fractures. Thank you very much for listening. That's all.
Thank you very much, Dr. Kim, for nice presentations. We will take questions end of the presentations. We can start second speaker, Dr. Ender Ofluoğlu, will talk about augmentation techniques in vertebral fracture. End of the presentations, we will ask questions. Okay?
Okay.